Welcome back to the Deep Dive. We're here to cut through the noise, get to the core of what matters, and turn complex info into clear insights. Today, we're diving into something really critical in healthcare, but often pretty complex for many: infective endocarditis, i.e., it's a serious infection right at the heart, literally, of our circulatory system. Way more intricate than just, a simple bacterial thing. But here's our mission today. We are going to unpack this. We want you to understand it with the depth and clarity of the absolute top pros in this field.
Exactly. Infective endocarditis, or i.e., it's profound, a really serious condition. It mainly hits the heart valves, yeah, but the ripples spread everywhere, often with devastating effects across the whole body. So our goal today, our deep dive, is really designed to transform how you understand this disease. We'll take you right from that first tiny microbial foothold through the most sophisticated ways we diagnose it, all the way to the life-saving treatments. It's not just about knowing what happens. We want you to get the why. Equip you with that deep knowledge that really marks mastery so you grasp how all these complex pieces fit together.
Okay, so let's start right there, defining the battlefield. If we're going to understand this opponent, what's its signature feature, the core lesion clinicians are looking for right away?
Right. The absolute defining characteristic is something called a vegetation. That's the prototypic lesion, the real centerpiece of the whole infection. Structurally, you should think of this vegetation as this complex, almost living mass. It's made up mostly of platelets, clotting cells, and fibrin, another key protein for clotting. And trapped inside that sticky mesh, that's where you find the actual microorganisms causing the trouble, plus a few of the body's own inflammatory cells trying, usually unsuccessfully, to fight back. Imagine like a miniature biological fortress forming right on a hard structure. It acts as this fortified base where microbes can hang out, multiply, and continuously launch attacks systemically. This vegetation, if it's the central point, it really dictates how the disease progresses and the effects it has. Without it, you just wouldn't look the same clinically.
That paints a really clear and frankly kind of scary picture. It's not just floating around, it's building a home base. Now, most people hear infective endocarditis and immediately think heart valve infection, but the source material says it's not always just the valves. Where else can this infection take root?
That's a really crucial point. Valves are definitely the most common sites, yeah, and clinically the most significant usually.
Yeah.
But this infection, it can set up shop in other critical spots in the cardiovascular system. For instance, you might find these vegetations on the low pressure side of a ventricular septal defect, a VSD. That's, a hole between the heart's lower chambers. The turbulent blood flow there, it can cause tiny injuries, perfect little attachment points for bacteria. Same idea for the mural endocardium. That's the inner lining of the heart chambers themselves. If that lining gets damaged, maybe by weird blood jets from another heart issue, or even by foreign bodies like catheters.
Like pacemaker wires.
Exactly. Intracardiac devices, pacemakers, defibrillators, they're a huge and growing site for these infections. They introduce foreign material right into the heart. And we should probably briefly mention infective endarteritis too. It's basically the same process, but it happened outside the heart in the large blood vessels. Think arteriovenous shunts or a patent ductus arteriosus, that vessel that's supposed to close after birth, or even a coarctation of the aorta narrowing. Same principle. Turbulent flow, potential damage, perfect spot for infection, just not inside the heart chambers or on the valves.
So the blood flow dynamics and any damaged tissue or foreign stuff, absolutely key to where these things decide to, set up shop. The source also mentions different flavors of IE, classifying them by how fast they develop. Can you break down the key differences between acute and subacute forms? What's the real aha moment there?
Yeah, that acute versus subacute distinction is fundamental. It's one of the first things that guides clinical suspicion and management. It really boils down to the tempo, the speed of the disease. Acute, i.e., the source calls it a hectically febrile illness. Think of a sudden aggressive assault. It progresses really fast, alarmingly fast. It rapidly damages heart structures, valves mostly, and it seeds infection elsewhere in the body, sends out little infected bits, emboli, that cause damage far away. Untreated, it can kill within weeks, sometimes even days. It's a true emergency. Subacute IE, though, it's much more indolent. Sneaky. Think of a slow creeping threat. This form damages the heart slowly, if at all. It rarely metastasizes widely. It just kind of gradually progresses, maybe over months. It might go unnoticed for a while, unless it gets complicated by a major embolic event, the big piece breaks off, or a ruptured mycotic aneurysm, which is an infected, weakened artery bursting. So the key insight, the aha moment for anyone trying to master this, is that the speed of onset and the severity of damage are critical for that initial classification. It immediately tells doctors how suspicious to be, how fast to act, how urgent the situation is. It's not just descriptive. It's a vital diagnostic and prognostic clue that demands different levels of immediate attention.
That difference alone really hammers home why recognizing it early and acting fast is so critical. Okay, let's zoom out a bit. Who gets? I.e., it seems like the profile has shifted over time. What are the big picture trends?
You're right. The epidemiology, the who gets it, has really changed, especially in developed countries. Historically, the big player was chronic rheumatic heart disease, damage from untreated strep throat. That's still a major factor in developing countries, definitely. But here in developed nations, we've actually seen a steady increase in IE cases over recent decades. And what's really noticeable is a big jump among the elderly. This shift away from rheumatic heart disease reflects huge changes. Societal aging, yes, but also medical advancements. It's created a whole new set of risk factors, changing who's most vulnerable today.
So, if rheumatic heart disease isn't the main driver here anymore, what are the modern risk factors? What are these new pathways for infection that have opened up?
Well, this is where it gets really interesting and, honestly, a bit ironic. Medical progress, while amazing, has unintentionally created new vulnerabilities. So the big modern risk factors. First, injection drug use, or IDU. That's a major and unfortunately growing risk factor. It puts bacteria straight into the bloodstream. Second, as people live longer, degenerative valve disease, basically, heart valves wearing out, becomes much more common, simple aging. And third, that rapidly expanding category, intracardiac devices, pacemakers, defibrillators, and increasingly, those transcatheter valves, like TAVR.
Right, the ones put in less invasively.
Exactly. While they're life-saving, they introduce foreign material, creating surfaces where bacteria can grab hold. It's like giving the bugs a new place to live, right inside the heart. Let's dig into those categories a bit more, because the details matter if you want real mastery here. For native valve endocarditis, NVE, that's infection on your original valve, about a quarter to a third of cases in developed countries are now linked to healthcare exposure. Healthcare associated, i.e. maybe from a hospital stay, a procedure, dialysis.
Okay. And prosthetic valves.
Prosthetic valve endocarditis, PVE, is a big slice of the pie, maybe 16% to 30% of all IE. The risk is highest in the first year after surgery, then it drops off. And interestingly, the risk seems a bit higher for bioprosthetic valves, the tissue valves, compared to mechanical ones. Maybe they're just a bit easier for bacteria to stick to. Within PVE, we have that newer category, PAVR PVE, infection after a transcatheter aortic valve replacement. The incidence is roughly 1.4 to 2.8 cases per 100 patient years in that first year, then lower.
Similar to surgically implanted ones, then.
Pretty similar to surgically placed bioprosthetic aortic valves, yeah. Less invasive procedure, but the infection risk is still very real and comparable in some ways. And finally, cardiac implantable electronic device, i.e. CIE-IE, pacemakers, defibrillators, resynchronization devices. The overall incidence isn't huge, maybe 0.5 to 1.14 per 1,000 recipients, but millions have these devices. The source notes a slightly higher risk with defibrillators and resynchronization devices than basic pacemakers, maybe due to more wires, more complexity. So what this really shows you, the learner, is this complex interplay. Medical progress saves lives, but it can also create new weak spots for infection. The landscape of who's at risk for IE is constantly shifting, and professionals have to adapt constantly.
That's a fascinating look at how the risks have evolved. Okay, let's talk about the actual culprits. When we say infection, we need to know the enemy. Who are the main organisms causing IE, and where do they typically come from before they attack the heart?
Right, identifying the microbial players is absolutely critical. You need to know who you're fighting. While yes, lots of different bacteria and fungi can cause occasional IE cases, the bulk of infections, especially in recent big studies from developed areas, are caused by just a few key bacterial species. And the single most common one, the top of the list right now, is Staphylococcus aureus, S. aureus. It's really emerged as the dominant player, a tough bug. Now, where do they come from? The portals of entry. There are definite patterns here which professionals look for. Viridans, Streptococcus for example, usually come from the mouth, the oral cavity. That's why dental health is so important, especially for high-risk folks. Staphylococcus, like S. aureus and the coagulase negative types, they mainly come from the skin. Breaches in the skin are a major entry point. The HAC organisms, that acronym for Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, Kingella, they often originate in the upper respiratory tract. Then you have the gastrointestinal tract. That can be the source for Streptococcus galolyticus subspecies galolyticus. Used to be called S. bovis.
Ah, the one linked to colon issues.
Exactly. Finding that bug in IE is often a big red flag for underlying colon polyps or even cancer. IE can be the first sign. Really important connection there. And finally, Enterococci. They most often get into the bloodstream from the genitourinary tract. Understanding these typical origins, vital for diagnosis and also for thinking about prevention. It's core knowledge for mastery.
So the context really matters. The patient situation, whether they have a device, it changes the likely suspects. Does the setting, like a hospital or having a prosthetic valve, significantly alter that typical microbial profile we just talked about?
Oh, absolutely. Context is king here. Knowing the setting or the patient-specific situation dramatically shifts the odds on which bug is responsible. This is a key diagnostic clue. Let's break it down by scenario. For healthcare-associated IE, remember this is a big chunk of native valve cases now. Here, the usual suspects are S. aureus, coagulase negative Staphylococcus, Con S, and Enterococci. These are bugs often found in healthcare settings. About half of these are truly nosocomial acquired right in the hospital. The other half are community onset but linked to healthcare contact, like dialysis or home infusions. And think about this. IE complicates somewhere between 8% and 25% of catheter-associated S. aureus bloodstream infections. A simple 5E line infection can become IE, serious stuff. Now, prosthetic valve endocarditis, PVE. Timing is everything here. Early PVE within 2 months of surgery is usually nosocomial. Contamination during surgery or right after, so the bugs reflect that. S. aureus, Con S, gram-negative bacilli, sometimes fungi. And crucially, a huge chunk of those Con S, maybe 68-85%, are methicillin resistant. That changes treatment options significantly.
Late PVE more than a year after surgery looks more like community-acquired native valve, i.e. the bugs and entry points are similar. For TAVR PVE, the bugs are generally similar to other PVE, but with a definite uptake in Enterococci. Risk factors include being male, having diabetes, kidney failure, or a leaky valve after the TAVR procedure. CIE, i.e. the device infections. This involves the device pocket, the leads, or where the leads touch the heart. Sometimes it infects the valves too. Presentation timing is spread out, about a third within 3 months of messing with the device, a third between 4 to 12 months, and a third over a year later. The main culprits, overwhelmingly S. aureus and Con S. Again, pointing to the skin is the likely source. And finally, IE in people who inject drugs, PWID. This often hits the tricuspid valve, the right-sided valve, very commonly caused by S. aureus, and often it's MRSA, introduced directly via injection. But the causes in PWID can be more diverse too, sometimes gram-negatives like Pseudomonas, Candida fungus, even unusual bacteria like Bacillus or Corynebacterium. Interestingly, having HIV doesn't really change which bugs cause IE and PWID, though it affects overall management, of course. So yes, the setting, the device, the patient's circumstances, they profoundly shape the microbiology. A detailed history is like gold for the medical detective here.
That's incredibly detailed, really drives home how context shifts the likely culprit. But what about the really puzzling cases? Someone clearly has IE symptoms, their body is screaming infection, but the blood cultures keep coming back negative. What's going on there? How do clinicians tackle culture negative IE?
Culture negative IE. That's a real diagnostic headache, a true test for professionals. It happens in about 5% to 15% of patients who definitely have IE. There are basically two main reasons this happens. First, maybe in about a third to half of these cases, it's because the patient got antibiotics beforehand, maybe for a fever, a presumed UTI, whatever. Those antibiotics can suppress the bacteria enough so they don't grow in the culture, even though they're still causing the infection. They're essentially hiding.
Makes sense. And the second reason?
The second reason is infection by fastidious organisms. Think of these as the incredibly picky eaters of the microbial world. They're just really hard to grow in standard lab conditions. They might need special nutrients, different atmospheric conditions, or just way longer incubation times, sometimes weeks, not just days. Examples: some Streptococci, especially those nutritionally variant ones like Granulocytella and Amyotrophia, the HACE group we mentioned earlier. Others include Coxiella burnetii that causes Q fever and Bartonella species. Sometimes there are geographic clues too. Coxiella and Bartonella are seen more in Europe, Brucella more in the Middle East. Some specific tricky ones. Trophorema whipple causes a really sneaky, often feverless culture negative, i.e. Coxiella loves prosthetic valves. Corynebacterium and Propionibacterium acnes are often linked to device infections and grow super slowly. And there's an emerging threat, Mycobacterium chimera. It caused a global outbreak of PD linked to contaminated heater-cooler units used during heart surgery. Very hard to culture from blood. And crucially, professionals always have to remember that some non-infectious conditions can mimic culture negative, i.e. things like antromyxoma, a heart tumor, or morantic endocarditis, sterovedgetations in cancer patients, or antiphospholipid syndrome. So why is it so tough to identify these bugs? It means clinicians need a high index of suspicion. They have to use other tools beyond just blood cultures, special antibody tests, serology, advanced molecular tests like PCR on blood or valve tissue, or sometimes the only way to know for sure is to get a piece of vegetation during surgery and analyze it directly. It's a high-stakes diagnostic puzzle.
That sounds like a serious diagnostic challenge needing real medical detective work. Okay, let's shift from identifying the enemy to understanding how it attacks. How does this infection actually get started? Is our heart normally shielded from these bugs?
Right, let's get into the pathogenesis, how it all begins. This is where the molecular details get really fascinating for anyone aiming for deep understanding. Normally, the endothelium of that super smooth inner lining of the heart and blood vessels is remarkably resistant to most bacteria sticking to it. It's like nature's Teflon. So the critical first step, the trigger, is usually some kind of endothelial injury, a breach in the defenses. How does that injury happen? Often it's due to turbulent blood flow. Think of high velocity jets of blood hitting the same spot over and over, maybe from a leaky valve, regurgitation, or a narrowed one, stenosis.
Like sandblasting almost?
Kind of, yeah. Or it can happen on the low pressure side of a defect, like a VSD. That force can cause microdamage. This injury does one of two things. Either it allows really aggressive bacteria, like some S. aureus strains, to directly infect the damaged spot, or, more commonly, it leads to the formation of something called non-bacterial thrombotic endocarditis, or NBTE. NBTE is basically a tiny sterile clot, just platelets and fibrin that forms on the injured site. It's not infected yet. But this NBTE acts as a perfect sticky spot, a prime landing pad, for bacteria that happen to be floating by during transient bacteremia. When bugs briefly get into the blood, maybe from brushing your teeth or a dental procedure. The heart conditions most likely to lead to NBTE formation: mitral regurgitation, aortic stenosis, aortic regurgitation, VSDs, complex congenital heart problems. But NBTE can also happen in hypercoagulable states conditions where blood clots too easily. That leads to merantic endocarditis in cancer patients, or sometimes in lupus or antiphospholipid syndrome. So yes, the heart is normally protected. But certain conditions create that initial vulnerability, that breach, setting the stage for infection.
Fascinating. So the injury or the NBTE clot is like setting a trap. Once that's there, how do the bacteria actually latch on? What are the specific ways they manage to stick so effectively and start building that vegetation fortress?
Okay, so the trap is set. Now the bacteria, having entered the bloodstream somehow, encounter this vulnerable site. And their adherence mechanisms are remarkably clever, almost like targeted molecular weapons. Staphylococcus aureus, our main villain, is particularly ingenious. It has multiple ways to stick. It can even adhere to intact, undamaged endothelium. How? Well, local inflammation can make the endothelial cells express a protein called von Willebrand factor.
Okay.
And this factor acts like double-sided tape, sticking to both platelets and S. aureus. Sneaky. Alternatively, S. aureus can stick to injured endothelium by grabbing onto fibrin and von Willebrand factor that get deposited on the exposed tissue underneath. It just directly latches on. For most other bacteria, their main strategy is to stick to the preformed NBTE clot. They use it as an anchor. And this is where MS crams come in. It's a mouthful. Microbial surface components, recognizing adhesin matrix molecules.
Okay, MS.
Yeah, basically, think of them as highly specialized proteins on the bacterial surface. Molecular grappling hooks, bacterial superglue. They let the bacteria bind tightly to molecules in the NBTE or on the damaged endothelium. Examples. Many gram-positive bacteria have fibronectin-binding proteins. These are crucial. For S. aureus, they're actually required to invade intact endothelium, which might explain how it can sometimes infect previously normal valves. Scary thought. S. aureus also has clumping factor to bind fibrin. Enterococcus faecalis has specific proteins to grab platelets. Streptococci use things like glucans or feme adhesins they normally use in the mouth to stick inside the heart. This molecular dance, this battle at the microscopic level between the host and the pathogen, it's incredibly intricate. It shows just how bacteria exploit our vulnerabilities to start a potentially deadly infection. Real mastery involves understanding these molecular tricks.
That's incredible, the precision of how they latch on, so they stick. Then what? How does that tiny initial foothold turn into that dangerous growing vegetation that makes the patient so sick by constantly shedding bacteria?
Right, once they've stuck, if they can survive the body's initial defenses in the blood and the local environment like antimicrobial peptides from platelets, they start to multiply rapidly. They form these dense microcolonies. Imagine a tiny, packed city of bacteria growing on the heart valve or lining. And here's a really crucial part. The bacteria themselves actively manipulate our clotting system to build their fortress. They trigger more platelet deposition. They make the local environment procoagulant more likely to clot. How? They trick endothelial cells, and for Escherichia, even our own immune cells called monocytes, into releasing tissue factor, a key trigger for clotting. They're literally using our own systems against us to build their defenses. Wow. So this cascade, more fibrin gets laid down, more platelets aggregate, and the bacteria keep multiplying that generates the full infected vegetation. Now, here's the critical point for treatment, something professionals absolutely grasp. The bacteria deep inside that vegetation, they're often metabolically inactive, largely non-growing, like they're hibernating or playing dead.
Which makes them resistant to antibiotics.
Exactly. Many antibiotics work best against bacteria that are actively growing and dividing, so these dormant bugs deep inside are much less susceptible. That makes the vegetation incredibly hard to sterilize completely with drugs alone. Yet, despite this, bacteria are continuously shed from the surface of the vegetation into the bloodstream. This creates that persistent bacteremia, the constant presence of bacteria in the blood. And that continuous shedding is what drives so many of the systemic symptoms. The fever, chills, aches as these bacteria travel throughout the body, potentially seeding infection in other organs. It's a vicious cycle, really hard to break.
That's a really vivid picture of the infection building its base and then attacking relentlessly. Now, you mentioned acute and subacute forms. So the symptoms must vary a lot, right? How does the specific bug influence whether it's a sudden storm or a slow creep?
Absolutely. The clinical picture of IE is incredibly variable. It runs the gamut from that explosive, acute onset to a really slow, insidious, indolent course. And yes, the main driver of that tempo is usually the microorganism itself. For instance, aggressive bugs like beta hemolytic streptococci, Asterias pneumococci, they usually cause an acute rapid illness. S. aureus can occasionally be subacute, but mostly it's fast and furious. Even some Con NS like Staph lugdunensis or certain enterococci can present acutely. On the flip side, subacute IE is typically caused by things like viridins, streptococci, other enterococci canis, the HAC group. These tend to cause a more gradual onset, slower progression, harder to spot early. And then you have the really, really slow ones, exceptionally indolent. Think Bartonella, Trophorema whipli, Coxiella burnetii, Mycobacterium chimera. These can simmer for months, maybe even a year or more without obvious traumatic symptoms. They're hiding in plain sight. Even the fever pattern often differs. Subacute, usually low-grade fever, rarely over 103 degrees F or 39.4 degrees C. Acute, often higher fevers, under 3 degrees, 104 S4EC, 104 degrees C. But importantly, fever can be blunted or even absent in some folks, the elderly, the very debilitated, those with kidney failure. That can make the diagnosis really challenging, even for experts. Understanding the likely bug helps anticipate the clinical course.
Okay, so beyond fever, what are the other common signs and symptoms someone might have, the body's alarm bells? And what do doctors usually see in blood tests that point towards IE?
Right, there's a whole constellation of signs and symptoms reflecting that systemic nature of the infection. Professionals learn to look for these patterns. Based on our source material, which often uses tables like 128-2 to summarize this, general constitutional symptoms are super common. Fever, as we said, 80-90%. Chills and sweats, maybe 40-75%. Loss of appetite, weight loss, malaise, feeling generally unwell, 25-50%. Muscle aches, myalgias, joint pains, arthralgias, 15-30%. Even back pain shows up in 7-15%, which can sometimes be misleading if you're not thinking IE. On the physical exam, clinicians are hunting for specific clues. A heart murmur is heard in most, 80-85%. But the really key finding is a new or worsening regurgitant murmur, a leaky valve sound found in maybe 20-50%. That screams valve damage from IE. And a large spleen splenomegaly in 15-50%. Clubbing of the fingers or toes, that characteristic shape change, 10-20%. Petechiae, those tiny little red spots under the skin, 10-40%. And those classic peripheral signs, the stigmata of IE, Osler's nodes, painful bumps on fingers, toes, subungual hemorrhages, splinter bleeds under nails, Janeway lesions, painless spots on palm poles, Roth spots in the eyes. These occur less frequently now, maybe 2-15%, but they're very suggestive when present, often reflecting immune system activity. And the lab tests often show a lot of inflammation and immune response. Anemia is very common, 70-90%. High white blood cell count, leukocytosis, in 20-30%. Microscopic blood in the urine, hematuria, in 30-50%. Elevated inflammatory markers like ESR, 60-90%, and especially CRP, over 90%. Positive rheumatoid factor in about 50%. Circulating immune complexes are found in almost everyone, 65-100%, and sometimes decreased complement levels, 5-40%, showing the immune system is being consumed.
So it really affects the whole body systemically.
Exactly. It's a disease that can manifest almost anywhere, making it a real diagnostic challenge that requires putting all these diverse clues together.
Given it starts in the heart, what specific heart problems arise? Beyond just the new murmur, how does the heart itself react to this invasion?
Great question. The cardiac consequences are central to IE's danger. While murmurs might be there already due to underlying valve issues, that new or worsening regurgitant murmur is a direct sign of ongoing damage. It means the infection is physically destroying the valve leaflets, or sometimes rupturing the chordae tendineae, those little parachute strings holding the valve leaflets. They can just snap. It's worth noting, in acute IE on a previously normal valve, you might not hear a murmur initially, but as the damage progresses, about 85% will develop one. One of the most feared cardiac complications and a major reason for surgery is congestive heart failure, CHF. This happens in 30-40% of patients.
And that's from the valve just not working anymore.
Primarily, yes. Severe valve dysfunction, the damaged valve leaks badly or gets obstructed by the vegetation, leads to blood backing up, causing CHF. Less often, it can be from intracardiac fistulae, abnormal connections formed by the infection, burrowing through heart tissue. Another major concern professionals always look for is paravalvular abscesses. This is when the infection spreads beyond the valve leaflet, digging into the surrounding tissue, the valve ring, or even the heart muscle itself. These abscesses can cause more destruction, leading to fistulae new murmurs. And as an aortic paravalvular infection is particularly dangerous because it can burrow into the septum, the wall between the ventricles.
Disrupting the heart's electrical system.
Precisely. It can hit the conduction system and cause varying degrees of heart block, which can be life-threatening. Mitral abscesses are a bit further away, so less likely to cause heart block, but still very serious. And lastly, though less common, about 2% of patients get coronary artery emboli. Bits of vegetation break off and block a coronary artery, causing a heart attack. So the direct cardiac damage is profound and drives much of the immediate danger.
It's staggering how it impacts the heart directly, but you mentioned it spreads. What are the broader effects outside the heart, especially the neurological ones? This really expands the battlefield, doesn't it?
Right.
It absolutely does. The non-cardiac manifestations really highlight the systemic nature of IE. A lot of these happen because of embolization. Bits of that infected vegetation break off, travel through the bloodstream, and lodge in distant organs, causing infection or infarction, tissue death due to lack of blood supply.
Cool.
Or the persistent bacteremia can seed infection elsewhere, or immune complexes can deposit and cause damage. Those classic peripheral signs of subacute IE, like Janeway lesions, we see them less often now with earlier diagnosis. But septic emboli mimicking these signs, like splinter hemorrhages or Osler's nodes, are still pretty common, especially in acute SA, IE. Musculoskeletal pain is common too, but you have to distinguish it from actual metastatic infection, like spondylodiscitis, infection in the spine, which happens in a significant 10-15% of cases. Focal infections seeded by the blood can pop up almost anywhere: skin, spleen, kidneys, bones, meninges around the brain. Arterial emboli are clinically obvious in up to half of patients, and here's a startling fact. About half of those emboli occur before IE is even diagnosed. That damage is already happening. Yeah. Risk factors for emboli include S. aureus infection, big mobile vegetations, 10 millimeter, and mitral valve infection. The consequences: pain, organ dysfunction, kidney, spleen, gut, limbs shutting down. Cerebrovascular emboli, strokes, or brain dysfunction, encephalopathy are a major complication, occurring in 15-35% of cases. And get this, even if patients don't have stroke symptoms, MRI scans find evidence of silent brain emboli in 30-65% of people with left-sided IE.
Silent.
Yeah, small blockages that didn't cause obvious deficits, but are still there. The risk of stroke is highest right before diagnosis and drops off significantly once effective antibiotics are started. Importantly, a late embolus during or after treatment doesn't necessarily mean the antibiotics failed. Other nasty neural complications: meningitis, aseptic or pus-filled, brain bleeds, from strokes turning hemorrhagic or from ruptured mycotic aneurysms, seizures, mycotic aneurysms. Those are weak spots, bulges in arteries, caused by the infection weakening the vessel wall. Really dangerous if they rupture. Brain abscesses can happen too, especially microabscesses with S. aureus, though big ones needing drainage are less common. And the kidneys can take a hit too, often from immune complex deposition causing glomerulonephritis. Usually gets better with treatment. Emboli can cause kidney infarcts too, leading to flank pain and blood in urine, but usually not complete kidney failure. So, yeah, systemic reach is vast. It's why managing IE requires vigilance across multiple organ systems.
It's clear IE can show up in so many ways, hitting different organs. A real diagnostic puzzle. Do certain patient groups, like people who inject drugs or those with devices, present differently? Are there unique patterns clinicians learn to spot?
Yes, absolutely. The presentation can be quite different depending on the patient's background and risk factors. Professionals definitely learn to recognize these specific patterns. For people who inject drugs, PWID, a large chunk, maybe 35-60%, have IE limited just to the tricuspid valve on the right side of the heart. These patients often present mainly with fever. They might have a very faint murmur or none at all, because right-sided murmurs are harder to hear, and they often lack those classic peripheral skin signs we see with left-sided IE. What's really characteristic, though, are septic pulmonary emboli. Infected clots travel from the right heart to the lungs, causes cough, chest pain, characteristic spots on chest x-ray, sometimes serious lung complications like emphysema. If PWID get aortic or mitral valve IE left side, it usually looks more typical. For healthcare-associated IE, the presentation is often typical unless it's related to a device, or if the patient has lots of other illnesses going on that mask the IE symptoms. That can really delay diagnosis. With CDIE device infections, you might see an obvious infection at the pacemaker pocket, especially if the device was recently manipulated.
Or it could be bacteremia, seeding the device leads without any pocket signs. Patients often have fever, maybe signs of sepsis, minimal murmur, and sometimes those pulmonary symptoms from septic emboli coming off the leads in the heart. Late onset PVE, prosthetic valve infection 1 year post-op, and TAVR-PVE usually present with typical IE features just on the artificial valve. But early PDE within 2 months can be tricky. The symptoms might be masked by the recent surgery recovery. A key feature in both early and late PVE is the high frequency of paravalvular infection burrowing around the valve ring. This often leads to partial valve dehiscence. The valve comes loose, causing new murmurs, heart failure, or conduction problems like heart block. So yes, these specific contexts create unique clinical pictures. Understanding them is crucial for rapid and accurate diagnosis.
This really does sound like a complex detective case every single time, piecing together clues from everywhere. So how do clinicians actually pull it all together, the symptoms, history, exam, labs, to make a definitive diagnosis?
It absolutely is like detective work, demanding sharp observation and synthesis. While the gold standard, the truly definitive diagnosis, often requires actually looking at the vegetation under a microscope after surgery or autopsy. In daily practice, we rely heavily on a system called the Modified Duke Criteria. These criteria are designed to be highly sensitive and specific. They integrate all those clues we've been talking about, the clinical signs, the lab results, and especially the echocardiogram findings into a standardized framework. But, and this is key for any professional using them, they are a guide, not a rigid checklist. Clinical judgment is always paramount. You have to interpret the criteria in the context of the individual patient. The Duke criteria basically sort patients into 3 bins based on the evidence. Definite IE. This requires a strong combination of evidence, either 2 major criteria or R1 major plus 3 minor criteria, or just 5 minor criteria, rejected IE.
This is used if you find a clear alternative diagnosis that explains everything, or if symptoms vanish quickly, AFI 4 days with minimal antibiotics, suggesting it wasn't IE, or if surgery autopsy finds no evidence of IE, again, after AFI days of antibiotics. Possible IE. This category is for cases that meet either 1 major plus 1 minor criterion or are 3 minor criteria. Generally, patients meeting definite or possible criteria are treated as having IE, given the risks of undertreatment.
Okay, can we unpack those criteria a bit? What makes something a major criterion? Those seem like the big smoking guns.
Exactly. The major criteria are the cornerstones, the most powerful indicators. There are 2 main types. First, positive blood culture. But it's not just any positive culture. It has to meet specific conditions. Finding typical microorganisms known to cause IE, like viridin strep, S. galolyticus, A. sec, S. aureus, or community-acquired enterococcus without another clear source, in 2 separate blood cultures. Or demonstrating persistently positive blood cultures. This means finding the same bug in cultures drawn 12 hours apart, or in most of several cultures drawn over at least an hour. That persistence reflects the continuous shedding from the vegetation. Or a single positive culture for Coxiella burnetii, or specific high antibody levels against it. The second major criterion is evidence of endocardial involvement, usually seen on imaging. A positive echocardiogram showing specific things. An oscillating intracardiac mass, the vegetation, on a valve or supporting structure, or in the path of a leaky jet, or implanted material without another explanation like a clot or tumor. A positive echocardiogram showing specific things, or evidence of an abscess near the valve. A positive echocardiogram showing specific things, or new partial dehiscence of a prosthetic valve that's coming loose. A positive echocardiogram showing specific things. Or, crucially, new valvular regurgitation. Just a change in an old murmur isn't enough. It has to be a new leak.
Got it. And the minor criteria, what kinds of things fall into that category?
The minor criteria are findings that are suggestive of IE but less specific on their own.
They add weight to the diagnosis when combined with other criteria. They include 1. Predisposition.
having a known heart condition that increases risk, or being a person who injects drugs. 2. Fever. Temperature 38.0 degrees C, 100.4 degrees Zeradou. 3. Vascular phenomena. Evidence of emboli, major arterial clots, lung infarcts, mycotic aneurysm, intracranial bleeding, conjunctival hemorrhages, or those Janeway lesions. 4. Immunologic phenomena. Things like glomerulonephritis, kidney inflammation, Osler's nodes, Roth spots, or a positive rheumatoid factor test. 5. Microbiologic evidence, a positive blood culture that doesn't meet the strict major criteria. The example, only one positive culture of a typical bug, or finding an atypical bug, or serologic evidence, antibody test pointing to an active infection consistent with IE. So you can see how the Duke criteria systematically combine all these different types of evidence to arrive at a probability of IE. It's a really robust framework when used thoughtfully.
Blood cultures really are central, especially as your major criterion. How do you collect them properly to maximize the chance of catching the bug, especially if you suspect IE? And what's the thinking on starting antibiotics before you have the results?
Excellent question, because getting the cultures right is absolutely fundamental. Poor technique can really mess things up. So for any patient with suspected IE native valve prosthetic TAVR device, if they haven't had antibiotics in the last 2 weeks, the standard protocol is this. Get 3 sets of blood cultures. Each set should have 2 bottles, one aerobic, one anaerobic, and you need adequate volume, usually 10 millimole per bottle for adults. Critically, these 3 sets should be drawn from different venipuncture sites, different veins, ideally spaced out over an hour or 2.
Why different sites and spaced out?
Drawing from different sites helps distinguish true bacteremia from skin contamination. If the same bug grows from multiple sites, it's much more likely to be real. Spacing them out increases the chance of catching the bacteria if the shedding from the vegetation is intermittent, though in IE it's usually continuous. Now, if those first 3 sets are negative after, say, 48 to 72 hours, especially if suspicion is still high, you should draw 2 or 3 additional sets. And definitely talk to the microbiology lab. They might use special culture media or hold the cultures for longer incubation, hunting for those fastidious bugs. As for starting antibiotics empirically before you know the bug, it's a real balancing act. If the patient is hemodynamically stable, not critically ill, the ideal approach is often to hold off on antibiotics initially after drawing the cultures. This gives the best chance of identifying the organism definitively. However, if the patient has sepsis, is rapidly deteriorating, or looks like they might need urgent surgery, you absolutely do not wait. You draw the initial 3 sets of cultures immediately, and then start broad-spectrum empirical antibiotics right away. You have to treat the immediate threat. It's a judgment call based on the clinical situation.
Okay, that makes sense. But for those tricky fastidious organisms, the ones that just won't grow easily, what other tests can help find them? Are there more advanced, maybe molecular ways to get an ID?
Yes, definitely. When standard cultures fail, we have to bring out the specialized toolkit. Serologic tests looking for antibodies in the patient's blood can be very helpful for specific culprits like Brucella, Bartonella, Trophorema whipli, and Coxiella burnetii. The body mounts an immune response. We can detect that. If the patient has surgery or an embolectomy, removal of an embolus, analyzing the vegetation tissue itself is incredibly valuable. You can try to culture the organism directly from the tissue, but you can also do histopathology, look at stained tissue under the microscope for bacterial shapes and patterns. Sterile collection is absolutely key here. And then we get into molecular diagnostics. This is a huge area. We can use broad-range PCR targeting universal bacterial genes like 16S RNA or fungal genes like 28S RNA. If the PCR is positive, we can then sequence the amplified DNA to get a specific ID.
So you can find the bug's DNA even if it won't grow.
Exactly. It's great when the pathology looks like IE, but cultures are negative. But there are caveats. PCR tells you the DNA is there, but not necessarily if the bacteria are alive or dead. And it's not perfectly sensitive. A negative PCR doesn't completely rule out IE. If tissue is limited, molecular tests might be prioritized over culture. And the really cutting-edge stuff, next-generation sequencing, sometimes called shotgun metagenomic sequencing, directly on the patient's serum, blood. This can potentially identify DNA from a huge range of organisms without needing to culture anything. It's a powerful tool for those really tough culture-negative cases, getting us closer to solving those diagnostic mysteries.
Beyond the lab tests, actually seeing the heart is critical. What imaging tools are the go-tos for confirming, i.e. finding complications? What are their strengths and weaknesses? How do pros use these visual clues?
Imaging is absolutely fundamental. It's how we visualize the battlefield inside the heart. The workhorse is echocardiography, using ultrasound. We usually start with transthoracic echo, TTE. The probe is on the chest wall. It's highly specific if it sees something definitive, but the image quality isn't always great, maybe inadequate in 20% of people. Its main limitation is sensitivity.
Right.
TTE can miss vegetations, especially small ones, 2 millimeter, and might be negative in 20-35% of patients who actually have IE. It's also not great for looking at prosthetic valves, especially TAVR valves, or for finding complications like abscesses. So if TTE is negative or unclear but suspicion is high, or if we're dealing with prosthetic valves or potential complications, we move to transesophageal echo, TE.
Where the probe goes down the throat.
Exactly. It gives much clearer, closer views because the esophagus is right behind the heart. T finds vegetations in over 90% of definite IE cases. But even T isn't perfect. It can have initial false negatives in 6-18% of cases, especially with TAVR valves. So if clinical suspicion remains high after negative T, repeating it in 7-10 days is often necessary to catch changes. We also now have 3D TE, which adds another dimension, literally. It's especially helpful for complex PVE device infections and getting a really good look at abscesses, fistulas, or valve perforations. What if echo is still unclear or contraindicated? Other tools come into play. Cardiac CT angiogram, CTA, specifically ECG-gated multi-slice CT, is increasingly used. It's about as good as T for finding vegetations. It might actually be better for defining the extent of paravalvular infection, how far an abscess is spread. Crucial for surgical planning. Then there's 18FDG PBT. This uses a radioactive tracer that gets taken up by areas of inflammation or infection.
So lights up infected areas.
Sort of, yes. It's less sensitive than echo or CT for seeing the vegetations inside the heart in NBE or CIEDE, but it's really valuable for suspected PVE, including TAVR, infected grafts, finding extracardiac infection sites throughout the body, or checking the device pocket. Its findings can actually change the treatment plan in about a quarter of patients by revealing hidden infection spots. Downsides: it's expensive, needs patient prep, can have false positives after recent surgery, and needs expert interpretation. But its value is recognized. The European guidelines even include PTCT findings as a potential major criterion now.
That's a serious imaging arsenal. But going back a step, what if someone just has, say, Staph aureus bacteremia, a common bloodstream infection? Is there a way to predict who's at high risk of also having IE, maybe to guide who needs those intensive imaging tests like TET?
That's a really practical question, especially with common infections like S. aureus bacteremia, where IE is a known but not universal complication. Yes, researchers have developed IE risk prediction scoring systems precisely for this purpose. They help identify patients with bloodstream infections from typical IE-causing gram-positive bugs who are at high enough risk to warrant an echocardiogram. Our source references Table 128-4 for these. For S. aureus bacteremia, which we know carries a high risk of IE and death, echo is generally recommended for everyone. These scores help refine which echo and how urgently. If a patient with S. aureus bacteremia has any of the high-risk features listed in the table, things like a prosthetic valve, prior IE signs of emboli, maybe persistent bacteremia, the risk of having IE is at least 6%, often higher, that strongly suggests needing an early T. If none of those high-risk features are present, a good quality TTE might be enough initially, although T might still be needed if clinical suspicion persists.
Similarly, for bloodstream infections with Enterococcus or non-beta hemolytic streptococci, having any 3 of the listed risk factors in the table suggests a significantly increased likelihood of IE, pointing towards needing echo. These scoring systems seem pretty good at identifying low-risk patients. They have high sensitivity and negative predictive value, so they can potentially help avoid unnecessary TEs in people unlikely to have IE. But, as always in medicine, they're tools to aid judgment, not replace it. Clinical assessment remains key.
That sounds like a really useful tool for navigating those common scenarios. Beyond the specific IE diagnostics, what other routine tests are important just for managing the patient overall?
Right, besides the tests aimed squarely at diagnosing IE, a battery of other routine studies is crucial for assessing the patient's overall status and managing the complexities of the illness and its treatment. These include a complete blood count, CBC, to check for anemia, look at white blood cell counts for signs of infection or medication side effects. Creatinine levels are vital for monitoring kidney function. Kidneys can be damaged by the infection itself, immune complexes, or by some of the powerful antibiotics we use, like aminoglycosides or vancomycin. Liver function tests are also standard, again, to monitor for potential medication toxicity. A chest x-ray is usually done to look for signs of heart failure or those septic pulmonary emboli, especially on right-sided IE. And electrocardiography, ECG, is essential. We need to watch closely for any new heart rhythm problems, especially conduction delays or heart block, which could indicate the infection is burrowing into the heart's electrical system. We also often see those general inflammatory markers we discussed being elevated ESR, CRP, rheumatoid factor, immune complexes. They confirm a significant inflammatory process is ongoing.
For specialized imaging, sometimes a cardiac CTA is used before surgery instead of a traditional cardiac catheterization to check the coronary arteries, especially in lower risk patients. And if there are any neurological signs or symptoms, even just a weird headache, a brain MRI is crucial to look for strokes, bleeds, or those dangerous mycotic aneurysms. Findings there can dramatically alter management, maybe delaying surgery. But experts generally caution against routine whole-body CT scans, just searching for silent emboli if the patient has no symptoms. The yield isn't high enough to justify the contrast dye risk to the kidneys. Every test has its place and purpose in the comprehensive management plan.
Okay, we know how to find it. Now, how do we fight it? This is clearly a serious infection. What are the core principles of using antibiotics for IE? What makes it so challenging?
Treating IE with antibiotics is definitely challenging, requiring a very strategic approach. The main goal is simple to state but hard to achieve. Kill all the bacteria within that vegetation fortress. The difficulty lies in a few key things. First, local host defenses are poor inside the vegetation. Immune cells can't easily get in there to help clear the bugs. Second, as we discussed, many bacteria deep inside are metabolically inactive, basically dormant. This makes them much less susceptible to antibiotics that target active growth processes.
Right, the playing dead bacteria.
Exactly. So the therapy has to be intensely bactericidal. It has to actively kill bacteria, not just stop them from growing. And it has to be prolonged, usually for weeks, to ensure eradication. Antibiotics are almost always given parenterally, usually IV. This is to get high enough concentrations in the blood so the drug can diffuse passively deep into the vegetation and reach those hidden bacteria. Deciding whether to start empirical therapy treatment before you know the exact bug is always a tough call. You have to balance the risk of the disease progressing if you wait versus the need to get control, especially if urgent surgery might be needed. When choosing empirical drugs, you have to think about likely pathogens based on the clinical picture, other infection sites, patient allergies, kidney or liver function, potential drug interactions. It's a complex calculation. For prosthetic valve endocarditis, PVE, the antibiotic regimens are often similar to NVE for most bugs. Staph is a bit different, but the duration is usually several weeks longer. That foreign material just gives bacteria more places to hide and persist. And the duration of therapy is always counted from the day blood cultures turn negative, confirming you've gained initial control. Durations might need adjusting based on kidney function, or if the patient has significant side effects. It's a long, demanding course of treatment.
So the specific bug dictates the specific drugs. Can you walk us through the strategies and maybe some challenges for treating the main culprits? Not every single drug, but the thinking behind it for professionals.
Absolutely. Tailoring the regimen is key, and the strategies differ significantly. Let's hit the major groups. Streptococcus. For many strep infections, especially Verdin strep, the good news is they're often highly susceptible to penicillin-type drugs, like penicillin G or ceftriaxone. The main decision point is often duration, typically 4 weeks. Sometimes, for very susceptible strains in uncomplicated native valve cases without complications like abscesses, a shorter 2-week course might be possible if you add an aminoglycoside like gentamicin for synergy. But professionals know this shorter course is not for PDE or complicated NVE. You always have to watch gentamicin toxicity, especially kidneys and hearing. If the strep is more resistant to penicillin, or if it's one of those tricky nutritionally variant bugs, Granulocutella aviotrophia, then you need longer courses, often 4 or 6 weeks, and combination therapy is usually required to get that killing effect. Enterococci, these guys are inherently tougher. They're naturally resistant to many common antibiotics. Penicillin, ampicillin, even vancomycin used alone, they usually only inhibit enterococci, they don't kill them effectively.
So the core strategy here is synergy. You need to combine a cell wall agent, like ampicillin or penicillin, with an aminoglycoside, usually gentamicin, to get that bactericidal punch. It's a classic 1-2 combination. Ampicillin plus gentamicin is often preferred because it might be less toxic to the kidneys than vancomycin plus gentamicin. There's some evidence that shorter courses of gentamicin, maybe 2-3 weeks, can still be effective and reduce toxicity. Another promising synergistic option, especially for E. faecalis, even if it's gentamicin resistant, is high-dose ampicillin plus ceftriaxone. Seems effective and less nephrotoxic.
What about vancomycin combinations?
Crucially, vancomycin plus gentamicin is not reliably bactericidal for E. faecalis, and vancomycin plus ceftriaxone also doesn't work well synergistically. For really tough multi-drug resistant enterococci, especially E. faecium, which is often vancomycin resistant VRE, is a huge challenge. Often needs an infectious disease specialist, maybe high-dose daptomycin, sometimes in combination. Source control is also key.
Staphylococcus aureus and con S. Given how common methicillin resistance, MRSA, MRSA is, empirical therapy almost always has to cover it, usually starting with vancomycin or maybe daptomycin. If it turns out to be methicillin susceptible, MSSA, you switch to a more targeted beta-lactam like nafcillin, oxacillin, or cefazolin. These are generally more effective than vancomycin for MSSA. Standard duration is 6 weeks for left-sided IE. Adding gentamicin or rifampin to the mix for S. aureus NVE is generally not recommended routinely anymore. For MRSA NVE, it's vancomycin, carefully monitoring levels, or daptomycin. There are nuances here, concerns about vancomycin failing if the bug isn't fully susceptible, vis-a-vis, and any higher daptomycin doses for left-sided disease.
If vancomycin isn't working, salvage options might involve daptomycin combinations or newer drugs like ciftarelin. Again, expert consultation is often wise. Source control is absolutely critical for staff getting rid of infected lines, draining abscesses. If bacteremia persists, you have to hunt for a hidden source. For staphylococcal PVE, it's usually a longer course, 6 to 8 weeks, and a multi-drug. Rifampin is essential here because it penetrates biofilms on the prosthetic material, but you wait to add rifampin until the initial drugs, like vancomycin plus gentamicin, have cleared the bloodstream to prevent resistance. So yeah, it's highly tailored strategic warfare against each specific bug.
That detailed strategy really highlights the complexity. What about when you don't know the bug yet?
Yeah.
Or if the cultures just stay negative, how do you choose antibiotics then? It seems like walking a diagnostic tightrope.
It absolutely is a tightrope walk. When you're starting empirical therapy or dealing with true culture-negative IE, you have to make educated guesses based on the clinical picture and likely pathogens. For empirical therapy in acute IE, patient is very sick, needs treatment, NA-BU. You need broad coverage. Think MRSA, maybe resistant gram-negatives, especially if it's healthcare-associated or in PWID. A common starting combo might be vancomycin plus an anti-pseudomonal beta-lactam like cefepime, or maybe vancomycin plus gentamicin. Covers a lot of bases while you wait for cultures. For empirical therapy in subacute NVE, the tempo is slower, maybe less likely to be aggressive resistant bugs. Vancomycin plus ceftriaxone is a reasonable start, covering common strep, staph, enterococci, and NG-TEP. For empirical therapy in PVE, if the valve is 1 year old, early PVE, you worry more about hospital bugs. So broad combo like vancomycin plus gentamicin plus cefepime is often used. If it's late PVE, 1 year looks more like NVE, so the empirical regimen might be similar to culture-negative NVE. For truly culture-negative IE,
once you've reasonably ruled out the common stuff, especially if no prior antibiotics, you start targeting those fastidious organisms. A regimen like vancomycin plus ampicillin sulbactam or ceftriaxone covers many possibilities. If Bartonella is suspected, maybe cat exposure. Adding doxycycline makes sense. If the cultures are negative because of prior antibiotics, you have to think, what bugs would that specific antibiotic have likely suppressed? It requires some deduction. For TB or PVE, empirical therapy is similar to other PVE, but keeping in mind that higher frequency of enterococci. And for CIE, remember, antibiotics are secondary to device removal. The regimen targets the known or suspected bug, but salvage without removal is rarely successful long term. If someone relapses after treatment for a bloodstream infection with a device in place, CIE-DIE becomes highly likely, and removal is usually needed. It's all about using clinical clues to make the best probabilistic choice while gathering more data.
It sounds like a really long course of IV therapy is the norm. That must be tough on patients. Are there any newer approaches, maybe switching to oral antibiotics partway through or doing IV therapy at home?
That's a really important point for patient experience and healthcare costs, and yes, there's been progress, but with important caveats. The traditional standard has been weeks of IV antibiotics, often meaning a long hospital stay or complex home IV care. But recently, studies have looked at partial oral antibiotic treatment. The idea is to start with IV therapy to get control, and then switch to highly bioavailable oral antibiotics to finish the course. One large randomized trial, the POET trial, suggested this could be non-inferior, basically, just as good for mortality in carefully selected patients with left-sided IE from certain bugs. Strep, enterococci, MSSA, notably no MRSA. Patients were switched after a median of 16 days of IV therapy.
So it's possible for some.
It seems possible for some, yes. But professionals need to be cautious here. That study enrolled only about 20% of the patients screened. It was a highly selected group. They were stable, often had surgery already, and were closely monitored. So we can't just generalize these findings to all IE patients, especially more complex cases or those with resistant organisms. While promising, switching to oral therapy requires very careful patient selection, ensuring the oral drug is appropriate and absorbed well, monitoring adherence, and close follow-up. It's not yet a standard approach for everyone. Then there's outpatient parenteral antimicrobial therapy, OPATE. This allows stable patients to finish their phobia therapy at home. The criteria are strict. Patient must be clinically stable, no longer bacteremic, febrile, no signs of impending complications on echo. They need a stable home environment, reliable 5E access, and must be on an antibiotic suitable for outpatient use. Stable in solution, infrequent dosing, low risk of sudden severe side effects. The key principle is patient safety and efficacy. You don't compromise the necessary antibiotic regimen just to send someone home. So these alternatives offer potential benefits, but require meticulous planning and oversight.
With such long and intense treatments, monitoring must be crucial. What are the common complications from the therapy itself? And how do you track if the treatment is actually working?
Monitoring is absolutely vital throughout that long course. Adverse events from the antibiotics themselves are common, hitting 25–40% of patients, often weeks into therapy. So periodic blood tests are standard to watch for kidney toxicity, nephrotoxicity, liver toxicity, hepatotoxicity, and effects on blood counts, hematologic toxicity. For drugs like aminoglycosides, gentamicin, tobramycin, and vancomycin, we have to monitor serum drug levels carefully, adjusting doses to hit that therapeutic window effective enough to kill bugs, but not so high it causes excessive toxicity. It's a constant balancing act. Source control needs to be addressed, promptly removing infected lines, treating abscesses elsewhere. We track treatment success primarily with blood cultures. They should be repeated daily until sterile, especially for tough bugs like S. aureus. If fever returns during treatment, cultures are checked immediately, and we do follow-up cultures 4 to 6 weeks after finishing therapy to confirm cure.
How quickly should the cultures clear?
Usually pretty fast with the right drugs. Viridin strep, E. faecalis, HACE, typically within 2 days. MSSA on a good beta-lactam, maybe 3 to 5 days. MRSA often takes longer, even with appropriate therapy. If bacteremia persists longer than expected, it's a red flag, maybe reduced susceptibility, maybe an undrained infection source, maybe resistance developing. Persistent fever lasting 7 days despite antibiotics is also a red flag, prompting a search for complications. Abscesses, cardiac or extracardiac, other infections, or non-infectious causes like drug fever. Interestingly, the vegetations on echo don't always shrink dramatically, maybe half or unchanged even months after cure. So imaging resolution isn't the only measure of success.
Okay, one more treatment question. Given the clots and emboli risk, what about blood thinners? Anticoagulants or antiplatelets? It feels like you'd want to use them, but also risky with potential bleeding in the brain. How do you navigate that?
You've hit on a really complex and controversial area. It's a true tightrope walk for professionals. Patients with IE are at high risk for both clotting, emboli, and bleeding, hemorrhagic strokes, ruptured myocardic aneurysms. So the first key point for native valve endocarditis: studies have not shown that adding anticoagulants or antiplatelets reduces the risk of emboli. Therefore, they are not indicated solely for emboli prevention in NVE. The risk of bleeding outweighs the unproven benefit. However, many patients with IE do have other reasons to be on anticoagulation. Maybe they have a mechanical prosthetic valve or atrial fibrillation with high stroke risk, or they develop a DVT. In these cases, anticoagulation is generally continued or initiated unless there's a major contraindication, like a recent large stroke, evidence of brain bleeding, or an unruptured myocardic aneurysm. If anticoagulation is needed, experts often prefer heparin, unfractionated, or low molecular weight initially, because its effects can be reversed more quickly if major bleeding occurs.
If a patient does have an acute stroke, ischemic or hemorrhagic, while on anticoagulants, that therapy should usually be stopped or reversed, at least temporarily, to minimize further neurological damage. It requires incredibly careful weighing of the risks of clotting versus bleeding for each individual patient.
Okay, so sometimes antibiotics just aren't enough. When does surgery become necessary? This must be a huge decision. Who makes that call and what goes into it?
Surgery in IE is indeed a huge decision, and it's often the key to survival in severe cases. What's crucial for professionals to understand is that the indications for surgery are mostly based on observational data and expert consensus, not large randomized trials. So the evidence strength varies, and the decision has to be highly individualized. This absolutely requires a multidisciplinary team approach. You need cardiologists, cardiac surgeons, infectious disease specialists, often neurologists if there are brain complications, all weighing in together. Overall, maybe 25–40% of patients with left-sided IE end up needing surgery during the active infection, maybe slightly more often for PVE than NVE. Does surgery help? Retrospective studies suggest that for NVE, surgery based on current indications likely offers a significant survival benefit, maybe reducing mortality by 27–55%. The benefit seems greatest for those with the strongest indications and becomes more obvious over time, after 6 months. For PVE, the benefit is more specific, mostly seen in patients with intracardiac complications.
But you always have to balance this against the fact that cardiac surgery itself has risks. especially in sick, infected patients. Those risks can outweigh the benefits if the indication for surgery isn't strong enough. TVR PVE is particularly challenging. Many have an indication for surgery, but few actually get it because they were often deemed too high risk for surgery even before the TVR. Sometimes, a less invasive valve TVR is an option later after the infection is cured.
Given that complexity, what are the clearest, strongest reasons for surgery? The indications where surgery is considered essential for the best outcome. The non-negotiables.
Right, there are situations where surgery is generally considered necessary for an optimal outcome, where medical therapy alone is very unlikely to succeed or carries a much higher mortality risk. Professionals recognize these red flags immediately. First and foremost, congestive heart failure, CHF. If the patient develops moderate or severe heart failure or shock because the infected valve is malfunctioning badly, either severely leaky or obstructed, that's the major indication. Surgery aims to fix the valve, repair or replace, and restore function. Survival is significantly better with surgery in these cases, and critically, the benefit is greater the sooner you operate relative to the severity of CHF. You don't want to delay when the heart is failing. Second, paravalvular extension of infection. When the infection burrows beyond the valve into surrounding tissue, causing an abscess, fistula, or heart block. This is common, especially in PVE. Signs include persistent fever despite antibiotics, new conduction problems on ECG, or pericarditis. TE is key to finding it. This generally requires surgery to debride the infected tissue and repair the damage, especially if fever persists or complications like heart block develop. Third, persistent bacteremia. If blood cultures stay positive day after day, say for 7-10 days, despite appropriate antibiotic therapy, and there's no other explanation, like an undrained abscess elsewhere, it means the infection source in the heart is uncontrolled by drugs alone. Surgery is needed to remove that source. Fourth, lack of effective antimicrobial therapy. If the infection is caused by organisms that are inherently resistant to effective antibiotics like fungi, especially molds, Brucella, or certain highly multi-drug resistant gram-negative bacteria, then surgery is often the only way to achieve cure by removing the infected material. Antibiotics alone just won't cut it. Maybe a fifth, specific to prosthetic valves, a partially dehisced, unstable prosthetic valve. If the artificial valve is rocking loose, it needs to be surgically secured or replaced. These are the big ones where surgery is almost always the path to the best outcome.
Okay, those are the must-dos. What about situations where surgery isn't absolutely required for survival right now, but it's still very strongly considered because it significantly improves the long-term outlook?
Exactly. There are scenarios where the decision is more about improving long-term prognosis, reducing future complications, or dealing with particularly challenging infections, even if the patient isn't in any immediate heart failure or shock. Surgery is strongly considered here. For prosthetic valve endocarditis, PVE, if it's caused by S. aureus and there are intercardiac complications, even if not immediately life-threatening, surgery is often favored due to the high mortality of medically treated S. aureus PVE. Also, if PV relapses after what seemed like successful antibiotic therapy, surgery is usually recommended to prevent further relapse. For native valve endocarditis, NVE, several situations push towards surgery. A large 10 mm hypermobile vegetation, especially if the patient has already had one embolic event, like a stroke, and has significant valve dysfunction. The risk of another, potentially worse, embolus is high. A very large 30 mm vegetation, regardless of other factors, the sheer size suggests a high embolic risk and potentially difficult sterilization with antibiotics alone. Persistent unexplained fever, 10 days, and culture negative.
If you can't identify the bug, antibiotics aren't working, and the patient stays febrile, surgery might be needed for both diagnosis, getting tissue, and cure. Poorly responsive or relapsed, i.e. due to highly antibiotic-resistant organisms like Enterococci or gram-negatives, even if they aren't causing immediate hemodynamic collapse. If the drugs are clearly struggling or have failed once, surgery to remove the source is often the best bet for long-term cure. In these cases, it's about weighing the surgical risk against the risk of ongoing infection, future emboli, or relapse. It's a more nuanced decision, but often leans towards surgery for a better overall outcome.
Timing seems absolutely critical here. Emergent, urgent, elective. How does the team decide when to operate? What guides that delicate balance?
The timing is indeed crucial and requires careful balancing. It's based on the severity of the cardiac complication and the risk of delay versus the risk of operating on an acutely ill, infected patient. Our source helps categorize this. Emergent surgery, same day. This is for truly life-threatening situations demanding immediate intervention. Things like severe valve dysfunction causing pulmonary edema or cardiogenic shock, acute aortic regurgitation causing mitral valve preclosure, a sign of extreme pressure buildup, and abscess rupturing into the right heart or the pericardial sac, leading to tamponade.
These are operate now or the patient die scenarios. Urgent surgery within 1-2 days. These are compelling indications where surgery is needed very soon, but there's perhaps a brief window for stabilization or further planning. This includes valve obstruction by a vegetation, an unstable loose prosthetic valve, acute severe heart failure, not quite shock yet, but close, large vegetations, 10 millimeter, with severe valve dysfunction or after a major embolus, a septal perforation, those very large 30 millimeter mobile vegetations, evidence of paravalvular infection spreading. Lack of effective antibiotic options for the identified bug. Elective surgery, timing less critical but earlier often preferred. This applies to situations where surgery is indicated for long-term outcome but isn't needed immediately to save life or limb. Examples: progressive leakage around a prosthetic valve, valve dysfunction with infection persisting after a week or more of antibiotics, stable but not clearing, fungal mold, endocarditis, staphylococcal PVE with complications if stable, early PVE within 2 months even if stable because of its high risk, candida endocarditis, i.e. from antibiotic-resistant bugs where medical cure is unlikely even if the patient is currently stable. The balance is tricky. You want to operate before irreversible damage occurs, but operating on someone with uncontrolled sepsis also carries high risk. For example, while infection can recur on a new valve after surgery for active, i.e. maybe 2% for NVE, 6-15% for PVE, that risk doesn't justify delaying surgery in someone with severe heart failure or uncontrolled infection. But if infection and heart failure are controlled medically, maybe a short delay to complete more antibiotic therapy is reasonable. It's a constant assessment.
What about those specific tricky scenarios, like if a pacemaker is involved, or if the patient has had a stroke? Do those change the surgical timing or approach?
Yes, those definitely add layers of complexity to surgical planning and timing. Regarding preventing emboli, we know antithrombotics don't work for this in NVE. Embolism risk drops quickly with antibiotics. So surgery solely to prevent emboli needs to happen very early. While large mobile vegetations identify high-risk patients, surgery just for this reason hasn't clearly shown increased survival. It's often a secondary benefit of operating for heart failure or uncontrolled infection. If surgery is done, trying to repair the native valve rather than replace it is often preferred, as it avoids introducing prosthetic material which could get infected later. For CIE device infections, the recommendation is crystal clear. Complete removal of all hardware, generator, and all leads is necessary for cure, usually done percutaneously. Removing the device during the initial hospitalization improves survival significantly compared to just trying antibiotics alone. If the patient still needs a device, a new one can be implanted at a different site after maybe 10-14 days of effective antibiotics. If the patient needs valve surgery for IE and has a CIE, the device should be replaced during that surgery. Timing with neurologic complications is perhaps the trickiest. Cardiac surgery can worsen brain injury. The risk depends on the type of complication and how recently it happened. General guideline: delay non-urgent cardiac surgery for 2-3 weeks after a large non-bleeding stroke, and for 4 weeks after a significant brain hemorrhage. This allows the brain to stabilize. General guideline: a ruptured myoclonic aneurysm in the brain must be treated surgically or endovascularly before cardiac surgery. General guideline. However, if a patient has an ischemic stroke, no bleeding confirmed on imaging, but needs urgent cardiac surgery for a life-threatening reason, and they're not comatose, then surgery should usually proceed early. Delaying might be riskier from the cardiac standpoint. General guideline: it's a very individualized decision requiring intense discussion between cardiology, surgery, neurology, and infectious disease experts.
So after the patient makes it through surgery, does that mean the antibiotics can stop? Or is there still a role for medication afterwards? What about long-term follow-up?
That's a critical question. Surgery removes the main nidus of infection, but it doesn't always mean the antibiotic course is finished. Even after recommended antibiotic therapy, sometimes bacteria or their DNA can still be found in the removed valve tissue. Usually these aren't viable bugs if cultured, and finding them doesn't automatically mean treatment failure. Relapse after surgery is actually uncommon. So the postoperative antibiotic duration depends on the situation. For uncomplicated NDE treated surgically, the total duration, pre-op plus post-op antibiotics, should simply equal the standard recommended course for that bug if treated medically. For uncomplicated NVE treated surgically, however, for complicated IE, like with an abscess, or partially treated PVE, or if the surgically removed valve is culture positive, then a full course of antibiotics should be given postoperatively, regardless of how much they got before surgery. You need to ensure complete eradication. For IE and PWID, standard antibiotic and surgical guidelines apply. But the crucial addition is aggressive management of the underlying opiate use disorder, OUD. Starting medication-assisted therapy, MAT, during the hospitalization and ensuring seamless continuation after discharge is vital. It dramatically improves antibiotic completion, reduces relapse of drug use, and lowers the risk of recurrent IE and repeat surgeries. It's treating the whole patient, not just the infection. And sometimes extracardiac complications need intervention too. Splenic abscesses, 3 to 5% of IE, often require drainage or splenectomy. Mycotic aneurysms, 2 to 15% of IE, half in the brain, need careful monitoring. Cerebral ones might resolve with antibiotics, but if they leak, persist, or grow, they need neurosurgical or endovascular treatment. Extracerebral ones are usually treated surgically. So yes, long-term management involves completing appropriate antibiotics, addressing underlying risks like OUD, and managing any lingering systemic complications.
After going through all of that diagnosis, intense treatment, maybe major surgery, what are the long-term prospects? What factors really determine how well patients do? What's the professional take on prognosis?
IE is such a varied disease, so outcomes really differ a lot. What professionals understand is that a poor outcome or death isn't always about the antibiotics failing. Often it's driven by the patient's other health problems, comorbidities, and the severe organ damage caused by IE itself. The heart failure, the strokes, kidney failure. The infection triggers a cascade, and sometimes the body just can't recover from the complications even if the bacteria are killed. Factors that generally point to a poor prognosis include having a prosthetic valve infection, PVE, infection involving the aortic valve, being infected with aggressive or resistant bugs like S. aureus, Pseudomonas, or fungi, developing serious intracardiac complications, abscesses, fistulae, having major neurologic complications, large strokes, hemorrhage, and having a healthcare-associated infection often means the patient was sicker to begin with. Despite all this, the overall survival rate in developed countries is actually pretty good, maybe 80–85%. But that average hides a lot of variation. NVE from less aggressive bugs, Verdin strep, HA6 susceptible enterococci. Survival is high, 85–90%. S. aureus NVE, non-IDU. Lower, maybe 55–70%. That bug is just nasty. S. aureus NVE and PWID. Initial survival is often good, 85–90%, but if the addiction isn't treated, 1 year mortality jumps to 20–30%. Treating the OUD is life-saving. Early PVE, 2 months post-op, mortality is high, 40–50%. Late PVE, 1 year, mortality is lower, 10–20%. KVR PVE, often in elderly, frail patients, in hospital mortality is very high, 35–50%, rising to 60–75% at 1 year. TVR PVE, often in elderly, frail patients. Overall, after successful treatment, maybe 80–90% survive 1 year, 70–80% survive 2 years. So it definitely has long-term consequences even for survivors.
Given how serious it is, the ultimate goal is prevention. Can we actually prevent IE? What's the current thinking, especially on using antibiotics prophylactically before procedures?
Prevention is the ideal, of course, but it's tricky, and the role of antibiotic prophylaxis has been really controversial and has changed over time. The current consensus from major groups like the AHA and ESC is to limit prophylactic antibiotics to only those patients at the highest risk of severe outcomes, morbidity or death, if they did get IE. Why the restriction? Concerns about promoting antibiotic resistance, potential side effects of antibiotics, and honestly limited evidence that prophylaxis prevents that many cases in lower risk individuals. The benefit just doesn't clearly outweigh the risks for everyone.
So who is considered highest risk and should get prophylaxis, particularly before dental work?
The guidelines target specific high-risk cardiac conditions. Anyone with a prosthetic heart valve or material used for valve repair. Patients with LVADs or those who've had a heart transplant and developed valve problems. Anyone with a previous history of endocarditis. They're at much higher risk of getting it again. Certain types of congenital heart disease. Unrepaired cyanotic conditions, completely repaired defects but only for the first 6 months after repair, or repaired defects with residual problems near prosthetic material. Certain types of congenital heart disease. Patients with surgically or transcatheter placed pulmonary artery valves or conduits. Certain types of congenital heart disease. It's worth noting UK's NICE guidelines shifted from basically stopping all prophylaxis to allowing more clinical judgment, showing this is still debated. But beyond antibiotics, the most important prevention strategy for everyone, especially those at risk, is good oral hygiene. Brushing, flossing, regular dental checkups, minimizing the bacterial load in the mouth is key. When antibiotic prophylaxis is recommended for those high-risk patients, it's specifically for dental procedures involving manipulation of gums, or the tooth root area, or perforation of the oral mucosa. Also for some respiratory tract surgeries. These are the procedures most likely to cause significant bacteremia.
What antibiotics are used?
Standard oral is usually amoxicillin. IV is ampicillin. For penicillin allergies, options include clarithromycin, azithromycin, cephalexin, or doxycycline orally, or cefazolin and ceftriaxone Livy. One important change. Clindamycin is generally not recommended anymore due to links with C. diff infection. Prophylaxis is generally not recommended for routine GI or GU procedures. The focus there is on treating any pre-existing infections before the procedure. And one specific prevention tip for patients with valve disease who get acute Q fever, treating it long-term, 12 months, with doxycycline plus hydroxychloroquine is very effective at preventing Coxiella burnetii IE. So this deep dive really shows that while IE is tough, our understanding keeps growing from the bugs tricks to diagnosis, treatment, and targeted prevention. It's about applying increasingly precise knowledge.
This has been an absolutely incredible deep dive. We've journeyed from those tiny vegetations building fortresses on heart valves through the complex web of diagnosis using criteria and advanced imaging, the strategic battles fought with tailored antibiotics, and the high-stakes decisions around surgery. It really highlights the multifaceted, precise approach needed to understand and manage IE like the elite professionals do.
Indeed. And mastering this, for anyone listening, is about seeing the connections, how the pathogen behaves, how the host responds, how our interventions fit in. It truly underscores the level of critical thinking and meticulous attention to detail this field demands. What connections or perhaps surprising details stood out most to you today as we navigated this?
I definitely feel much better equipped and honestly more appreciative of the hidden battles and the sophistication of the medical response. It's fascinating how every detail matters.
And that's the essence of these deep dives, isn't it? The more we understand, the more focused our questions become, pushing us to learn even more.
Join us next time for another deep dive as we continue to cut through the noise and get to the heart of what truly matters.